Recording started. We're officially going here. Let me get a pointer. That looks nice. I'll use this one. Oh, cool. So today I wanted to start with one of two lectures that we're going to do as introductory sessions on therapeutic apheresis. This will really be an overview, and for this first module, the goal was to kind of give everybody an overview to hook you and to get you all excited, and then the nitty-gritty will come a little bit later. So ordinarily we would give a bunch of case examples of apheresis. They're going to come a little bit later in the curriculum, in the program, and so I'm only going to offer a few examples today just to sort of show you. And then we'll get much more detailed later on in the academy on specifics of how you would prescribe apheresis, the conditions that you would prescribe. So again, today is going to be a bit of an overview. So let's start here. The first, somebody have a question? No. So the first issue that I like to start off with is this question: how pure is your blood? And now that you've been in the academy for a while, you can imagine that your blood is not very pure, and clearly it can often be contaminated by endogenous toxins, and this is going to be kind of the purview of dialysis and CRT. Exogenous poisons, that may also be the purview of dialytic therapies, although we may get involved in apheresis in these as well. Administered drugs can contaminate the blood: viruses, bacteria, antibodies, abnormal cells, and even excessive water. For therapeutic apheresis, primarily what we're going to be dealing with are these issues: exogenous poisons, the administration of drugs to toxic levels, antibodies and proteins that are abnormal or pathologic, and abnormal cells. And so you've got all of these contaminants in the blood, and we have a variety of different modalities to purify the blood, and oftentimes these extracorporeal therapies are designated as blood purification therapy. There may even be strategies there are strategies actually, extracorporeal strategies to remove viruses. We've dealt with some of those. Be nice if we had one for bacteria. We were involved in some projects a few years ago to try to deal with sepsis and bacteria, but we clearly can remove viruses from the bloodstream by extracorporeal techniques, and that's we're going to try and get one of our as a special guest lecturer, a person that was involved in designing the devices that would remove these viruses. And essentially, you could look at these extracorporeal blood purification therapies as just kind of a big net. You swing this net through the blood, and boom, all the bad stuff gets taken out into the net, leaving the blood as it leaves the net purified and goes back to the patient. So what is therapeutic apheresis? And again, apheresis comes from a Greek word, and generally what it means is to take away from or to remove. And so we would think of the process of therapeutic apheresis as being the therapeutic process that's associated with the withdrawal of blood from a donor's body, a patient's body or a donor's body, could be either one, and the removal of one or more components of that blood, either as plasma, platelets, white cells, or other components from the flowing blood, and then the transfusion or the reinfusion of the remaining components of that material, that blood, back to the donor. And this is called pheresis. If it's the plasma you're removing, we'd call it plasmapheresis. If it's cells that you're removing, it would be leukapheresis. Platelets, platelet pheresis, and then if it's red blood cells, usually it's called red blood cell exchange. But that's what apheresis means, to take away, to remove. This is the general schema of what happens, and this is the general schema for all extracorporeal therapies. We have blood that's got contaminants in it, and we'll identify the contaminants as these starry looking things that are associated with the blood that we're withdrawing from the patient. Generally, the blood is pumped out of the patient, and then it goes to magic box. And the magic box grabs the abnormal or the impure substances, removes them from the flowing blood, and then the purified blood goes back to the patient. And then all you have to do to identify the therapy that you're dealing with, replace the magic box with some other therapeutic device. In the case of dialysis and CRT, it would be an artificial kidney or a hemodialyzer. In the case of plasma exchange, it might be the centrifuge that we'll talk mostly about today, or it might be a plasma filter. In the case of hemoperfusion, then we would use an absorptive device in this flowing path to purify the flowing blood of these contaminants. Okay, makes sense so far? Very simple. Come on. And I think Dr. Foster kind of alluded to some of this in when he was talking about hemoperfusion. But if we look at the spectrum of molecules as a parameter of size, and so we've got small molecular weight solutes, generally up to 300-400 Daltons. We've got medium molecular weight solutes that would go from 400 or 500 Daltons, maybe to several thousand, maybe even up to 15,000. And then we've got these larger molecules that go up into the hundreds of thousands of Daltons. And then finally, we've got big stuff in the blood, which are cells. And for each of these different kinds of components of the blood, small molecules, medium molecules, big molecules, or cells, there's an extracorporeal treatment that's designed to deal primarily with those specific areas. And so for the small and sort of medium stuff, we've got hemodialysis and hemoperfusion, or hemofiltration rather, and to an extent hemoperfusion as well. Then when we start getting up into the larger molecular weight solutes, up to big stuff, then we get into the genre of plasma exchange, or another filtration technique we'll talk about in a few minutes, which is double filtration plasma pheresis. And then as you start getting up into the blood components, then we're dealing with leukapheresis or other kinds of exchange transfusion or other kinds of apheresis techniques that would remove those very large structures from the blood. So for today, we're going to primarily be discussing or really considering what do we do for this sort of category, of drug here. Plasma exchange extends all the way down to these very small solutes, because remember, these small solutes may be bound to bigger molecules in the blood, which are going to prevent their effective pheresis or removal by these more traditional techniques. And that doesn't exclude the fact that you also could remove small molecular weight substances that are dissolved or suspended in plasma water by doing a plasma exchange. So plasma exchange will really extend across this whole range, but depending on the size of the molecule, its distribution volume, and its protein binding, then we'll select one of these three modalities to deal with that. When we start getting up into these bigger molecular weight solutes, then it's clear that any kind of general dialytic technique is not going to be appropriate or effective, and so then we get into the purview of plasma exchange. And so let's talk about therapeutic apheresis as a general term, it just therapeutic, obviously meaning therapeutic, apheresis, to take away something. And it typically will fall into two major categories of therapeutic modality: therapeutic plasma exchange and cytopheresis. Most commonly what we'll deal with is therapeutic plasma exchange, although we're starting to dabble in cytopheresis for the management to provide some very sophisticated immunotherapy techniques for cancer, and this is something that is pretty cool. And we'll have a session or two about cytopheresis later on in the curriculum, and introduce you to some of these techniques for doing mononuclear cell collections, stem cell collections, or killer T cell collections. We don't do very much red cell exchange, but somebody tell me what's going to be the major indication for red blood cell exchange in patients. Any takers? Sickle cell, exactly. So in human medicine, this is one of the major therapeutic uses for cytopheresis is for sickle cell anemia, where you're simply going to take out all of these abnormal sickle cells and replace them with more viable cells. So we'll get into that a little bit later in the curriculum. For therapeutic plasma exchange, then we'll consider that modality of therapy when we're talking about immune-mediated diseases. And again, if we're dealing with an immune-mediated disease, we're going to be talking about either big antibodies, either IgGs or IgMs or IgAs, or potentially even immune complexes. And so there are a variety of opportunities and techniques and indications for using therapeutic plasma exchange to treat these immune-mediated diseases. And this is where we've had most of our experience, but we're branching out and starting to collect and accumulate more and more immune-mediated diseases that we're considering might be appropriate for these therapies. Another big one, I haven't personally treated a gammopathy yet, but Dr. Lippi in Pisa has done a couple of gammopathies, multiple myelomas, where you had these large paraproteins that were causing hyperviscosity type syndromes, and you can selectively target with some systems, or non-selectively target the plasma removal to get rid of these paraproteins and exchange them with plasma that is not pathogenic. We'd also use it to manage and remove large toxins, large toxic molecules that have accumulated in the blood or been administered to patients inappropriately. We can use it to replenish plasma constituents, and we have had some experience with this in patients with liver failure. And again, mostly in the context of amanita poisoning, where these patients have eaten these mushrooms and had severe necrosis and destruction of hepatic function, and their most immediate life-threatening phenomenon is bleeding, and you have to replace clotting factors. Well, and you would do that mostly with replacement of clotting factors through plasma exchange. But to do that, even in a small animal, you may have to give 10, 12, 15 liters of plasma. And there's no way that you're going to get 15 liters of plasma in a 5 or 10 kilo dog, or even a bigger dog. And so with plasma exchange, you actually can remove plasma to dig a hole, so to speak, for the replenishment of plasma that's going to contain these clotting factors, and you can really help regulate the bleeding tendencies of these hepatic failure patients by doing that. But you'd never ever be able to provide that much therapeutic plasma to a patient without having the ability to remove some of the volume that you're about to replace. And it's used in human patients for a variety of dyslipidemias, particularly hypercholesterolemias or patients that have other abnormal lipid abnormalities. It's fairly easy to remove these pathogenic lipids with plasma exchange. So that's sort of the spectrum of some of the areas that we're going to be interested in pursuing here. I just lost my clock again. Hang on. All right. Now, what are some of the indications for a therapeutic plasma exchange? And as we sort of talked about, situations where you've got pathologic autoantibodies, or not necessarily antibodies, but pathologic antibodies that are creating, I guess most of them are probably autoantibodies. They're reacting with normal body constituents and causing abnormalities. We've just mentioned about the gammopathies that are often associated with multiple myelomas. Antigen antibody complexes are a target. We haven't had experience with these yet, but clearly these are important targets. In transplantation, it's a very common feature to try to remove alloantibodies that might be specifically generated and attacking the graft. And many patients that are getting a variety of different kinds of transplanted organs will have to undergo apheresis or plasma exchange to get rid of these alloantibodies in order to get to prevent graft rejection and to get graft survival. That's actually a fairly large indication for apheresis in human patients. We've talked about, well, we haven't talked too much about endogenous toxins. Dr. Foster mentioned a little bit about treating hyperbilirubinemia with charcoal. We can reduce the bilirubin, maybe 10 or 15 milligrams per DL with a hemoperfusion treatment. But with plasma exchange, you can really drop the bilirubin concentration quite substantially if you think that the concentrations are high enough to cause neurologic signs or to be pathologic. Exogenous poisons, this is a big one that I think that we'll be getting more and more experience with, particularly with these poisons that are very highly protein bound and have very small volume of distribution. This in combination with another technique that we'll talk about a little bit later in the hour called plasma absorption. You can use the combination of these two techniques to pretty well purify the plasma of these exogenous poisons that are highly protein bound in a fairly manageable time frame. Or sometimes if we're presented with a patient that obviously is intoxicated with something, you don't know what it is, and you might consider dialysis and hemoperfusion. Plasma exchange would be another option for that, or plasma absorption, which I'll tell you about, which could give you very broad spectrum elimination of toxins. And as you remember from that slide earlier where we looked at the whole spectrum of toxins, and using something like plasma exchange, you could essentially eliminate something from very small to very big, from being non-protein bound to being highly protein bound. So this might be a fairly broad brush or a very wide net sort of therapy to provide for patients that have unidentified toxins. And then, as we just talked about, to replete depleted plasma constituents and particularly coagulation proteins. Okay. No questions so far. So I'm going to start off talking about centrifugal apheresis. There are two major ways of doing plasma exchange. One is a centrifugal technique. That's the technique that we're using here in San Diego and in Davis, and the technique that's been used in Philadelphia. There are other centers around the country, mostly research centers, that are also using centrifugal apheresis for doing plasma exchange. And then the other technique will be filtration apheresis, where you actually use a plasma filter to do the separation. But in centrifugal apheresis, much like you saw before, the abnormal plasma is withdrawn from the patient, generally pumped from the patient, and then goes into a centrifuge. And I'll illustrate this in more detail. And in the centrifuge, the components of the blood are separated out into their various categories according to their density or their weight. And then we select which piece of the plasma we want, or actually you can select which piece of the blood you want to remove. But if we're talking about plasma exchange, we would divert all of that waste plasma up into a waste bag. We would send the concentrated cells back out of the centrifuge, reconstitute those cells that have been separated from the plasma with a replacement solution, which may be fresh frozen plasma or some combination of replacement solutions to reconstitute the cells. And then the reconstituted cells are then delivered back to the patient. So this is centrifugal apheresis, where the components of the blood are separated from one another based on their densities in a continuous fashion in an external centrifuge. It's a cool technique. This is the device that is currently being used to do that. There are a couple of companies that make this. Baxter makes one. This is Trumo that makes the Opti. I think that's the one that's most commonly used in veterinary medicine. This is the real new fancy player on the block. But there are a couple of other companies that will make a centrifugal technique. This provides continuous centrifugal separation of the plasma constituents, and these components are separated by their density in the centrifugal force field. And so you can see that if we look at the major components of the blood, we've got plasma. That's the lightest component of blood, has a very narrow range of specific gravities. The next dense substance in the blood are the platelets. They usually layer just below the plasma. Then we've got various and variety of white blood cells that have a broader range of specific gravities, and we can actually break down component-wise these cells. And then the heaviest cell in the blood are the red blood cells. And by just simply taking advantage of these different weight characteristics of these components, we can stick them in the centrifuge and separate them out according to their density. So here's an example of a chunk of blood that has been separated out according to the density of those components. And so we can see the lightest component here is the plasma. Depending on how soft or how hard you spin and pack these cells, the platelets may be suspended or float in the plasma, or you may pack them down so that they're sitting just on top of the next dense layer of cells, which are the lymphocytes, and then all of the plasma is clear. And this is what we do in therapeutic plasma exchange. We do a very hard spin so that all the cellular components are packed down, and then we can kind of freely pull off the plasma without worrying about depleting the patient of the platelets that may be suspended in the plasma. When we're doing other kinds of leukapheresis, where we want to actually collect various cell layers, we might do a softer spin and get these cells to distribute in a little bit broader range. And then right below the platelets sit the lymphocytes, and then below the lymphocytes sit the monocytes and the stem cells. Then we've got granulocytes sitting right below the mononuclear cells, and then in the very bottom, the heaviest cell layer are the red blood cells. And we can make this kind of separation of these blood components by how we program or how we manipulate the centrifuge. And so the components initially are separated by their density, and there are ways that you can make these components, you can feed some cells some iron particles or do something like that to make them denser. But also we can use physics to help us make these separations, and so the size of the centrifuge is going to determine to an extent the opportunity to separate these components. The gravitational force, so the speed of the centrifuge, and the dwell time, how long you let the material sit there and be exposed to that gravitational force. All of those things can be dictated by the software in the machine to deliver the kind of treatment that you want to deliver. So here's just an example of the Optia, and what typically happens. You can see here's one of the nice features about the Optia. It has this nice cartridge that you can kind of direct and see all of the various components of the blood and where they're going and what they're doing. But we have a variety of pumps, and we've got this pump right here is the pump that's going to pump the blood out of the patient's body. So the blood comes, this would essentially be the arterial blood line that comes up here. It's going to go through a filter, through a pressure sensor, come down through this pump, and then be pumped around this way and boom, down into the centrifuge, which is down below this. And then the blood is going to come back from the centrifuge, and it's going to be pumped by this pump. The plasma is going to be pumped by this pump, separating off the plasma from the rest of the cellular components, and this pump is going to direct it through this maze in the cartridge, and it's going to send the bad plasma up to a big waste bag that sits up here, and I'll show you a picture of that later, that sits up here above the image. And then we've got a replacement pump that simultaneously is going to deliver the replacement solution through a kind of a convoluted track here, and it's going to reconstitute the concentrated cells, which are going to come up here. So you've got really packed cells that are going to come into this chamber. They're going to get mixed with the replacement solution, and then all of that material is then going to be pumped back to the patient by this return blood pump. So those are the four pumps that are manipulating most of the blood and plasma components. And then we've got one more pump that manages the anticoagulation while all this goes on, and we'll go over that in just a second here. Any questions about that circuit? This will go much more detail when we come back later in the curriculum and talk about more specifics of apheresis. But this is the way the centrifugal technique works. This is the centrifuge, and this is in a little compartment that's right below the cartridge. The blood is going to come down from the piece upstairs. It's going to go into some tubings that are essentially associated with the centrifuge, and right in this groove that goes around the rim of the centrifuge, we're going to put in a channel. And here's the channel, and so the blood's going to be pumped down into the centrifuge. It's going to enter the channel here. It's going to be pumped around the channel, and then it's ultimately going to be delivered to this little chamber. This is actually called a chamber, I think. And this is where all the major separation is going to occur. And I'll show you that here in just a second. So here's, those look like John's fingers, I think. John's finger putting the channel in the groove, and it goes around the entire perimeter of the centrifuge. And then right here is going to be this, this chamber that is going to provide the separation of all these materials. So just one more look. Here's this piece of the extracorporeal circuit. This is just one component of the whole extracorporeal circuit. Blood is going to come from the blood pump down into this part of the centrifuge, and it's going to be pushed or pumped around the centrifuge. And then when the blood comes and gets to the cartridge here, It's going to be separated into its various components, and then we can select off those components as we want. So this is just a close-up of that cartridge sitting here in the centrifuge. So here you can see this shows you the rim of the centrifuge going around. This is the direction of spinning. We've got centrifugal forces now that are acting on, so this is looking down on the top of the centrifuge. And we've got blood coming into this little chamber, and then these centrifugal forces are going to act on that blood and push the various components of the blood into these different layers, depending upon their specific gravity or their density. And then according to the little channels that we set an interface here, and then depending on where we set the interface between the blood plasma and the blood cellular components, we can suck off the piece that we want to suck off, and we can return the rest of the material that we don't want to remove back to the patient. So the red cells and the platelets would be taken off by this channel that goes back up and returns these concentrated cells and returns the white cells and the platelets back to the mixing chamber, and then this channel is going to pull off the plasma and send that up to the waste bag for elimination. Very silent out there. So that's centrifugal apheresis, where the separation is created by these centrifugal gradients that occur. The other kind of apheresis or therapeutic plasma exchange that you can do, this is the type of therapy that you would perform on a machine like the Prismaflex. If you have a Fresenius machine, there are attachments that you can buy for the Fresenius that will allow you to do some degree of plasma exchange. I suspect that you could use those devices and modify the Phoenix to do that, but it's not really designed for that yet. The advantage that you have on the Prismaflex is that there's software that's going to help control all of this. Otherwise, you're really sort of doing this all kind of manually. But with membrane plasma exchange, instead of using a centrifuge to separate the plasma from the cellular components of the blood, we use a very, very, very leaky filter. And these are devices that are called plasma filters, rather than a hemodialyzer or a hemofilter. These are plasma filters. And they have very big holes in them that are big enough to essentially allow all of the plasma constituents to pass across the membranes, but they're restrictive enough that they don't permit the cellular components of the blood to be passed. And so as the blood is pumped out of the patient and is pumped into the plasma filter, the cellular constituents are going to pass through these are almost exclusively hollow fiber devices. And so the cellular components are going to pass right through the hollow fibers into the return blood path, and the plasma, to a variable extent, is going to be sucked off or removed and delivered to a waste bag. And so here you can see the pathologic plasma is getting sucked off, and it's getting delivered to a waste bag. And then you would have a replacement solution, in this case fresh frozen plasma or some combination of fresh frozen plasma and other replacement solutions. That return plasma then is going to be pumped back at the same rate that it's being removed, reconstitute the concentrated cells that exist here at the interface, and then those reconstituted cells in that donor plasma then is going to go back to the patient. So all the characteristics that you can do this on a device like the Prismaflex, which makes it, have more capabilities in your program. Just here's an example of a plasma filter that again, very, very leaky membranes, and so it will permit the passage across the membranes of the proteins, electrolytes, hormones, anything that's big, even up to close to 1,000 kilodaltons, will be able to pass through the filter. But the platelets, the red cells, the white cells, all of those components are going to be restricted from passage, and they will pass through and exit on the efflux side of the membrane. Okay. So, what's the difference? And often, like hemodialysis and CRRT, or intermittent hemodialysis and CRRT, you could envision that there are going to be camps. There's going to be one camp that likes CRRT, one camp that likes intermittent hemodialysis, and to an extent, we do have camps that have evolved in human medicine to say, well, we do mostly centrifugal, or we do mostly plasma filtration apheresis. But in reality, when you look at it, both of these techniques really have fairly similar efficacy and fairly similar outcomes. And so from a therapeutic standpoint, they're probably not different for plasma exchange. It's alleged that the filtration method may be faster, and it is alleged to be faster because you can run the blood faster through this device than you generally can with this centrifuge, because most of the filtration exchange is done with heparin as the anticoagulant, where in apheresis, centrifugal apheresis, most of the time you're doing it with citrate. You can do this with citrate, but most of the people that do filtration apheresis probably use heparin. But in reality, probably the time for both of these techniques is probably fairly similar, because when you do centrifugal apheresis, you're pulling off 60 to 80% of the plasma at a time. But with the filtration technique, you can only remove about 25 to maybe 30% of the plasma with any single pass. Otherwise, you'll concentrate the cells too much, and you'll end up with clotting, or you'll concentrate the cells so badly that you'll get physical damage to the cells as you try to pull them off, and you'll get so much sludging that you'll get a big clot at this end. Typically, the filtration fraction is about 25 to 30%, whereas we get essentially about 80 to 85% extraction when we do centrifugal techniques. So the other feature to point out is, yes, they're very similar, but you really have to understand what you're doing if you're doing this technique, and you really have to understand what you're doing if you're doing this technique. And so it's not that one is easier than the other. They both have their nuances, and they both have their advantages and disadvantages, but it doesn't exclude the fact that if you're going to do one versus the other, you have to understand and know what you're doing to be safe. The other fundamental difference between these two techniques is, with filtration apheresis, you're limited to just plasma exchange, whereas with centrifugal apheresis, you have a much broader spectrum of techniques that you can use that includes site apheresis. And so if you want to get into some of the newer techniques of immunotherapy for cancer or for other kinds of diseases, the centrifugal technique is going to give you more flexibility in that regard. Only plasma exchange. There are reported techniques for doing site apheresis on these with filters, but generally you do site apheresis with a centrifuge. All right. Now, we can do some other fancy stuff with these techniques, and we can combine therapies. What if you had a patient that was severely uremic but also needed plasma exchange? Well, we can combine those techniques, and we can do therapeutic plasma exchange plus hemodialysis. Schematically, that's sort of represented here. We've got pathologic blood coming out of the patient. Maybe these are pathologic antibodies. Perhaps this is a patient with Lyme-associated nephritis, comes in, has a rapidly fulminant membranoproliferative glomerulonephritis, but also is severely uremic. And perhaps you wouldn't want to do those treatments sequentially. You might want to do them simultaneously because the patient needs to be treated with both technologies right now. And the dialysis is going to take you 5 hours. The apheresis may take you 4 or 5 hours. And so you don't really want to invest 9, 10, 12 hours in doing this. You might want to do them kind of simultaneously. It's tenable. It's possible. And to do that, then you would take the blood out of the patient. You would do the apheresis, the plasma exchange, by removing the pathologic antibodies, do the replacement fluid, and then hook the animal up to some dialytic system that's going to do the dialysis. Oh, come on. So here's how you would do it with membrane apheresis. Take the blood out of the patient, pump the blood out of the patient, run it through a plasma filter, pump out the abnormal plasma, so it's going to go down to a waste bag for removal, replenish the abnormal plasma with replacement plasma. It's going to reconstitute the cells. Now you've got a new blood, a purified blood, purified except that maybe it still needs to be dialyzed. Now we can take that purified blood and we can expose it to a hemodialyzer and do dialysis on that blood, and then return the plasma separated exchanged blood and the hemodialyzed blood then back to the patient. Here's an example where we did both using intermittent hemodialysis and centrifugal apheresis. Very easy to set these machines up so that we can provide both exchanges at one time. And since we've got a picture of the apheresis machine on here, let me just point out a couple things that weren't shown before. The centrifuge sits down in this door right here, and so you open this door up, and the centrifuge is down here in this part of the machine. There's the waste bag sitting up here, removing all the nasty plasma, and you can see that plasma doesn't look very healthy. And then mostly our replacement solutions sit on this side of the machine, going back to the patient. So in this case, what we did, and we'll show you this more later on, we just simply split the arterial blood coming out of the arterial limb of the catheter, sent some of it to the apheresis machine, we sent some of it to the dialysis machine, and we did that particularly in this case because these pumps run at different speeds, and it was very difficult to coordinate doing it in series, so we elected to do the treatments in parallel. On the Prismaflex, you actually can do them in series if you want. The cases where I've seen the Prismaflex used, they actually use an Optia to do the plasma exchange, and then they use the Prismaflex to do the dialysis. And you can set those machines up to either do them in series or in parallel. Generally, everybody pretty much considers that it's just easier and more straightforward to do them in parallel, even if you're using the Prismaflex. There are ways that you can hook them up to do them in series, but this is less complicated. Now let's introduce another technique that you can do. This is an advantage of membrane apheresis, and it's a technique called double filtration or cascade filtration. And in this situation, we take the blood out of the patient, so this is coming out of the arterial limb of the catheter, going through a plasma filter. And what's the plasma filter going to do? Quick question. Let's see what we got here. Oh, what would be the priming volume? The priming volume would be big. It would be the priming volume of the dialysis machine plus the priming volume of the apheresis machine, so it's going to be 250 mils or more. depending on how you configure each of those machines. All right, so oops, I lost my mouse now. My mouse won't go all the way over here. Here we go. So here's the plasma filter, and what's the plasma filter going to do? It's going to separate the cells from the plasma. We're going to pump the plasma. We're going to pump the plasma. We're going to pump all of the plasma out of the plasma filter. And then we can submit that plasma to a secondary device. And this is a secondary filter, but now this filter has other characteristics. It has characteristics that it has selectivity. And this filter now can select what proteins it's going to retain and what proteins it's going to let pass across the membrane, and what proteins it's going to not permit to pass across the membrane. And so let's just say that all of our pathologic antibodies were IgMs. They're going to be very high molecular weight antibodies, high molecular weight proteins. And so if we selected a filter, a secondary filter or a double filter or a cascade filter, all of those are terms that are used for this, that has a very high ability to pass the low molecular weight proteins that are exclusive of the big IgMs that are potentially going to contain the pathologic antibodies. We can select those off, and these are healthy proteins. These are proteins that don't cause any disease, so that we can select those off and not waste them. And then let the big proteins that are causing all the pathologic events, we can say, well, we don't want those to come off of this filter. We can waste those to the plasma bag. And now, since we've reclaimed all of these lower molecular weight plasma proteins that are non-pathogenic, we can divert those back to the cells and not have to use so much replacement fluid. All we have to replace here is potentially the volume that was contained with those high pathogenic IgMs. If we don't know, or if the pathologic antibodies are both IgGs and IgMs, then we can put a filter in here that selects smaller proteins, and so we can return the albumin or maybe the alpha and beta globulins and return all of those proteins that are not immunoglobulins to the patient, and that reduces the amount of plasma or the amount of constituents that we have to use as a replacement solution going back to the patient. So the advantage of this cascade system is that you might be able to do apheresis on the patient without having to replace all of the major expense, or one of the major expenses of this procedure, and that's the replacement plasma. So the majority of the expense is going to be here in the replacement fluids, the plasma that you give back. And so we can select secondary filters here, or cascade filters, that have different ranges of molecular selectivity according to what we want to keep and what we want to remove. Does that make sense for everybody? So this is a technique called double filtration or cascade filtration, and again, it's something that you can do on the PrismaFlex or the Braun platform that Dr. Lippi uses in Pisa. Claudio, I don't know, do you use the PrismaFlex or do you use the Braun machine for this?
Well, PrismaFlex is mostly dedicated from situation like immunomediated hemolytic anemia,
yeah.
Whereas the Braun is more on the project on the leishmania up to now, because the amount of the blood of the priming that is related to the set.
Yes, but you could do cascade filtration for any of these indications It would just depend on, I didn't know whether, I think you can do cascade filtration on the Prismaflex. It just depends on what device you use here. If you
Well, Prismaflex is very limited because Prismaflex is using a set that is dedicated to the Prisma. You cannot modify.
uh, I think I've seen modifications of that. They have a set now that you can actually select, at least in the United States.
Mostly because the pressure detector are
Yeah.
strongly related to the device you have. If you change the filter or whatever, the pressure detector don't work anymore. So we just had a case today, and so I don't think that you can modify the Prisma Flex sets.
For Cascade, okay.
Yeah,
I know
for
was using the Braun for that. Then there are other machines that you can do cascade filtration, but you can see by how you select this filter here, you can regulate which protein fractions you're gonna remove to the waste bag and which protein fractions you're gonna return back to the patient. So that's a fairly interesting and useful technique. Another interesting and useful technique that I think we'll use more and more and more of, and again, you could do this with either filtration apheresis or centrifugal apheresis, and this is the technique of plasma absorption. And plasma absorption is a technique where you would separate the plasma from the cells, and so we've got pure plasma coming across the plasma separator or the plasma filter. And then we would take that plasma and we would run that over an absorptive device that is that's sitting here in the circuit. And the reason that you might want to do this is that maybe the material, your absorptive material, is too toxic to the cells. And you can't expose the cells to that toxic material, but it'd be very effective at removing the material that you're trying to leach out of the plasma. Or it may be that that you think that the charcoal device, for example, is too damaging to the cells, and so this is a way that you could do the plasma exchange or do the hemofiltration without exposing the cells directly to the potentially injurious sorbent material that might be in your device. We also have devices that use the same principle, that use a membrane to separate the plasma out, but all the charcoal sits in the dialysate compartment of the device. So the material is filtered at one end. The filtered plasma goes into the dialysate compartment, flows down the chamber, and this is a closed system, unlike this one where we're actually siphoning the plasma off. The filtered plasma interacts with the charcoal or whatever sorbent is in the dialysate compartment, and then when it gets back down to this end of the device, it back filters across the membrane, reconnects with the cells, and then goes back. And this is a way of separating the cells from whatever sorbent material that you have that might be dangerous or toxic or damaging for the cells. So again, you can do this with filtration apheresis, or you can also do this with centrifugal apheresis. And so here's an example. This actually was an Amanita case, and what we really wanted to do was to decontaminate this patient of this Amanita toxin as much as we can. And this is a toxin that's about 99% protein bound, but we have past experiences, and we know that charcoal is very effective at removing Amanita, but we're going to want to treat for a long period of time, and we don't really want to have cells exposed to that charcoal for all of this period of time. And so what we did first, we did a plasma exchange. And with a single plasma volume of exchange, we removed 65% of the toxin with a plasma exchange. And then to continue with more plasma volumes, a plasma exchange would really constitute, and I'll show you that in the next couple of slides, would really constitute using large amounts of plasma that would get prohibitively expensive. So after we remove the first 60 to 70% of the toxin with a plasma exchange, then we simply put a charcoal filter in the line that would ordinarily go up to the waste bag. And so instead of sending that plasma to the waste bag, it gets diverted through the charcoal, and then the charcoal acts as a plasma absorptive device, and then we simply return the plasma that now has been charcoal absorbed back to the patient. And we don't have to deliver any more plasma, or we don't have to use any more plasma as a replacement solution. We can just simply run the plasma through the charcoal and let the charcoal absorb it out. And this is a technique that's likely to be quite effective in getting higher percentages of toxin removal without the necessity of providing such excessive amounts of plasma replacement. Here's just an example that we use as a demonstration. Here's an example of plasma absorption. So we're using the Optia to separate the plasma from the cells. The plasma is coming up, and this is an in vitro system. So we've put this purple poison in the patient, in our phantom patient, and it's separated the plasma containing this purple poison from the cells. Then we deliver that purple plasma to this charcoal absorber. Poison goes into the absorber, and look what comes out of the absorber. Nothing. So we've gotten 100% extraction of this material from this plasma absorber. This gives you an example of how efficient this can be. You've got really high concentrations of terrible, nasty toxin going into the plasma, the charcoal absorber, and purified plasma coming out. We can see it one more time, what you would see on the cartridge. So here's the line that takes the waste plasma up. Ordinarily would take the waste plasma up to the waste bag. So this is the line that takes the bad plasma to the bag. That's essentially now this line. Instead of putting it into the bag, we run it into the charcoal device. And this is the replacement line that's coming back. And you can see toxic, nasty material here going in, that is contained in the plasma, yet the purified plasma that's coming back to the patient to reconstitute with the cells is clear and been completely extracted from that patient. Okay, let's stop here. I'll continue this on Monday. So Friday we have a discussion and rounds, and I'll finish up with discussion. There's just a few more slides here, but we'll go ahead and stop early because I can add all this to Monday's lecture. We'll talk a little bit about platelet pheresis and then some other aspects that you need to consider just as an overview for doing therapeutic apheresis, particularly doing therapeutic plasma exchange. So any question? Purple colored. Who's asking? Oh, JD's answering that. Hey JD, just as an aside, so there's going to be probably next February is going to be the American Apheresis Society is going to have a meeting here in San Diego. Very, very good meeting for anybody who's interested in apheresis technologies and treatments. It's a 2-day meeting. We did this lab last year up at Renal Week last March. And JD was the one that ran the lab, and so his name is and face is associated with doing this lab. But Dr. Ward has invited me to come and give the lab at the apheresis meeting. So that'll be kind of cool.
Yeah, that's great.
Just one more comment related to the fact that JD commented that you can connect the Prismaplex system to the liver purification system, but it is really the Mars. But these are very limited systems that are not elastic. You cannot modify the system they are planned for. And so you cannot add or remove other filter or add other particular system to improve or change the mechanism they are planned for. This is the point.
Okay. I was probably misinformed about that then. So you're not going to be able to do cascade filtration on your Prismaflex, but you can do therapeutic plasma exchange. You can do plasma absorption, I would suspect, on the Prismaflex.
Sure.
Great. Thank you, Claudio. Any other comments?
Can I ask just general renal failure question, kind of poll?
Sure. We've got experts on this session here that could answer this.
Yeah, exactly. So it's regarding a case of nephrotic syndrome. She's a 5-year-old female intact St. Bernard who is presenting with diffuse peripheral edema and some lameness in her pelvic limb. She is moderately azotemic and progressive, so she's gone from B1 of 66 to 120, creatinine of 2.4 to 3.8 in the last 2 days. She has no other medical history with the exception of about a week of weight loss. And she is tick negative, lepto negative, urine culture still pending, but is at this point negative at 24 hours. And her edema continues to worsen. She has a normal blood pressure and is she's relatively oliguric, so she's somewhere in the range of about 1 ml per kg per hour, and we're just matching ins and outs. And her weight's been stable over the last 24 hours. So my question
Did you tell us the albumin?
Oh, sorry, it's 2.5.
Okay.
So the question or the debate in the hospital is, do we treat her with hetastarch to try to use as an oncotic pole? My feeling is I worry that it's not going to provide a lot of change in the peripheral edema, and she does have some abdominal effusion after starting fluids.
I have to ask a question. Are you treating this patient with fluids?
Yes.
Yes, I would have guessed that.
Matching ins and outs.
Yeah, but I'll just tell you my bias, and then hopefully we'll get some other opinions. I think it's uncommon that an animal that's got a 2.5 albumin that we see this kind of effusive fluids from that. It can occur occasionally, but you usually don't get gross peripheral edema until you start getting down to albumins of 1.2 or less, maybe 1.5 or less. So my first suspicion is that you've created this peripheral edema and ascites with your fluid administration, and maybe Lasix is the more, stopping the fluids and Lasix is the more appropriate therapy. That's kind of a bold statement, and so I'm anxious to see what other people might say.
Yeah, and I do agree. We did stop the fluids for about 12 hours until she was making, initially she was at 0.5 mils per kg per hour, and now she's up to 1. And we did give her 1 dose of Lasix. And like I said, her weight's been stable over the last 24 hours now.
And I guess that's a good question somebody's asking. So is this pitting edema or is this non-pitting edema?
Pitting edema.
Yeah. I bet I would just guess a huge component, and the animal may have vasculitis, and that's clearly, and you can speak up I would suspect that she could have vasculitis, and that's a component of it, but I think a big component of your progressive edema is likely to be your iatrogenic fluid therapy. Just my thought. Somebody else say something. Oh, somebody did. Shelley did. Oh, good. Thank you, Shelley. I'm always glad to be on board with you.
Did you check for the central venous pressure in this patient?
No, we don't have a central venous pressure.
Would we consider her a rapidly progressive type of dog, given the way her creatinine is changing, and consider the use of immunosuppressive drugs at this point?
And that was the next question.
Question. Fix both your problems.
How high is her UPC? I may have missed that. I'm sorry.
Sorry, I didn't say it, but she is a 3+. We were waiting to get the urine culture before we did the UPC just to make it more worthwhile. But she does not have any white cells. She does not have any red cells. She has a 3+ protein with a USG of 1018, and she does have trace glucosuria.
Other nephrologists out here, let's hear something from some other nephrologists. I mean, there are some card-carrying nephrologists.
I'm assuming lepto-negative?
Yes.
It would seem to me like the UPC is really critical because did she have any cytologic abnormalities on her urine sediment? I mean, why are you thinking she might have a UTI?
No, she doesn't have any cytologic abnormalities. And it was just the rule out of the UTI, so you're absolutely correct. At this point, we could certainly add in the UPC. We're, like I said, just trying to get it negative before we added that in.
Yeah, so usually if we don't have cytologic abnormalities suggestive of a UTI, we'll just go ahead and run the UPC. But I would, I think that it does look like obviously the animal's proteinuric. I'm not that impressed with her albumin. And what did you say her creatinine was?
She went from 2.4 to 3.8 in the last 24 hours.
And her blood pressure?
180.
Yeah, I mean, we always like to try to have a renal biopsy before we start immunosuppressives so that we can see if it's a immune complex mediated. And this dog is a little bit confusing because she seems to be oliguric with glomerular disease. I think that's kind of uncommon. And so it's just, again, it would be really critical to see what your UPC is. It seems to me like she's volume overloaded, which is going to reduce her albumin a little bit too, or has the potential to reduce your albumin.
And the other way we could explain the oliguria is with congestive nephropathy. And so if this patient is fluid overloaded, what we very commonly see now is as they start to get fluid overloaded, they go from being having a normal urine production or being slightly oliguric to anuric or profoundly oliguric because of a condition called congestive nephropathy. And you can imagine all of that expansion that's occurring in her limbs and all of her peripheral tissues. She can expand because that tissue is flexible, but the kidney's not flexible. It's surrounded by this dense capsule. But that organ is probably just as edematous as the rest of the dog, and that raises the intrarenal pressure, and that'll actually shut off filtration, and it'll shut off urine flow in the kidney. And it's very common to see these animals get progressively deteriorating urine production with that fluid administration. And then when we ultrafilter them and offload that fluid, very often they'll start peeing right on the table once you get the fluid gone and get the congestion repaired.
Yeah, and we witnessed that in our dialysis unit here too. I was a skeptic when I first, several years ago, heard Larry start talking about this, but I think it's absolutely true. And I would wonder if that's what's going on in your dog as well. Hemoperfusion.
Yeah, I completely agree. That's what I've seen as well. So she actually did start improving her urine production after we gave her those lasix and copper fluid. But then she dropped about 1.5 kg after that, and so then we're trying to keep up with
Your audio is breaking up a bit.
Sorry.
Yeah, better now. Yeah.
So she had dropped about 1.5 kg after we stopped the fluids and started the Lasix, and that's when we restarted the fluids to try to keep up with what she was putting out.
Yeah,
except she was already in a positive state, so she needed to get rid of some of that first.
Yeah, you have plenty of fluid on board that you didn't need to replace.
Okay.
That would be my approach.
Okay.
I don't think the head of starch is useful in this setting. It wouldn't last very long anyway. And again, I think if this is just cosmetic, so what? You don't need to deal with it. But I think you're getting to the point now that the edema is getting to be a bit pathologic, particularly if you are dealing with a congestive nephropathy. You just need to offload that fluid. And again, if the animal's anuric, you may not be able to get rid of it, with the exception of dialysis.
Right. And the azotemia isn't going to improve with anything except for dialysis or getting her kidneys functioning again.
But again, your progressive azotemia may be correlated with your progressive oligoanuria, and all of that may be secondary to the fluid overload. Even though it seems contradictory that we give fluids to reduce the azotemia, it's very common to see in this situation where you give an excessive amount of fluids and you generate more azotemia and more oliguria.
Yeah.
The other thing to keep an eye on too is if she's oliguric, do we have any previous lab work on her prior to the labs that you had? Was her albumin lower at any point? Because it's hard to lose albumin if you're not making pee. And so sometimes we see these animals where their UPC actually drops pretty significantly, even if they were prior to this very proteinuric. So is there any historical labs on her recently?
Unfortunately, no. She hadn't been seen by a vet in 4 years.
Okay. And she was how old? I'm sorry?
She's 5.
Okay, all right, so she's...
All right, so next week at RRR rounds, we'll expect an update on this case. And again, these are things that if we don't have discussions to talk about the academy on Friday, we can interject these kinds of discussions as well, because nephrology is certainly a very important part of all of this extracorporeal understanding. So but that's fair game. I think we want to try to reserve and get all of the extracorporeal issues discussed first on the Friday rounds, but we clearly can discuss these nephrology questions, and they're very, very good discussion questions for the RRR rounds on the alternate Fridays.
If I'm allowed, Cowgill, I have to make an update of the case I discussed last time because there are interesting information.
You want to do that on Friday?
Yeah.
Great.
Thank you very much. I appreciate it.
Didn't mean to come off sounding kind of dogmatic, but this is we see this so often that I was pretty sure I could say that with some confidence.
Well, it's
Okay.
actually how I was feeling to not give the head of starch, so I appreciate it as well. So.
All right, folks. Terry,
Thank you very much.
You have anything to say, Terry?
No, it's late. I'm not functioning very well.
We are already sleeping in Europe.
Almost, yes.
I close this session. I'm stopping the recording and see you folks on Friday.